Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
This section explores snake envenomation, a major global health issue causing morbidity and death. It details venomous snake families like Elapidae, Viperidae, and Lamprophidae, distinguishing front fang from non-front fang species by morphology and venom delivery. The text presents epidemiology, showing high incidence in rural tropical areas and data from the U.S., where pit vipers are most common. It explains venom composition, proteins, peptides, enzymes aimed at prey and defense, causing neurotoxicity, hemotoxicity, and tissue damage. Variability in symptoms depends on factors like snake species, age, geographic origin, venom amount, route, and patient health. Local effects at bite sites are described, along with the toxicology behind them. Management includes first aid, immobilization, avoiding tourniquets/suction, hospital care, and antivenom use. 2. FDA-approved antivenoms for North American pit viper bites, Crofab, and Anavip, and the North American coral snake antivenom, Naxav, are examined with dosing, safety, hypersensitivity, serum sickness, and allergic reactions discussed. Diagnostic tests and handling complications like paralysis, coagulopathy, and tissue injury are covered, emphasizing the importance of ongoing monitoring. Here are 10 brief learning objectives designed to help learners gain essential knowledge in managing snake envenomation. First, learners will be able to classify medically important venomous snakes into their primary families, which include Elapidae, Viperidae, and Lamprophidae, and differentiate them based on characteristics such as their fangs and venom glands. They will also summarize the epidemiology of snake bites both globally and within the United States, identifying the most common venomous snakes responsible for envenomations in the country and recognizing key demographic risk factors. Next, learners will describe the complex composition of snake venoms, outlining the major enzyme and protein types present, and explain how variability in venom influences clinical presentations. They will identify the principal clinical effects of snake envenomation, including neurotoxicity, hemotoxicity, myotoxicity, and local tissue injury, linking these effects to specific venom components. Furthermore, learners will distinguish universally recommended first aid measures for snake bites, such as immobilization, from harmful or non-recommended practices like applying tourniquets or making incisions. They will note the differences in application of these measures for bites from pit vipers versus coral snakes. The objectives also include outlining the critical steps in initial hospital management of snakebite victims. This involves stabilizing vital signs, conducting appropriate laboratory investigations, including the 20-minute whole blood clotting test, coagulation studies, and creatine phosphokinase levels, as well as continuous monitoring for signs of envenomation progression. Additionally, learners will explain the definitive role of antivenom therapy in snakebite management. They should understand how antivenom works to neutralize venom antigens and recognize that children require the same dosage as adults for effective treatment. They will compare and contrast the 2 United States Food and Drug Administration-approved antivenoms used for North American pit viper envenomations. The first is Crofab, derived from ovine sources, and the second is Anavip, derived from horses. learners will understand their origins, indications, dosing strategies, and their impact on late hematologic toxicity. The objectives also include recognizing and describing categories of adverse reactions to antivenom therapy. These reactions include immediate hypersensitivity responses such as anaphylaxis and alpha-gal syndrome, as well as delayed serum sickness, along with their appropriate management. Finally, learners will discuss the unique clinical presentation of North American coral snake envenomation, which is primarily neurotoxic. They will understand the specific indications, dosing, and safety considerations associated with the use of the North American coral snake antivenom. Globally, there are approximately 3,000 snake species, but only about 600 are considered to be clearly venomous. The classification of snakes has evolved to place venomous species into several families, including Colubridae, Natricidae, Elapidae, Lamprophidie, and Viperidae. Snakes are also categorized based on their morphology, particularly their fangs and venom-producing glands. Venomous snakes with fangs positioned toward the front of the mouth are known as front-fanged venomous snakes. This group includes well-known species such as cobras and vipers, which belong to the families Elapidae and Viperidae, respectively. These snakes have high-pressure venom glands that enable them to eject venom precisely. On the other hand, there are snakes with fangs located further back in the mouth or no distinct fangs at all. These are often referred to as non-front-fang colobroids. Their venom is produced in elongated, low-pressure glands called Duvernoy's glands, which may not allow for as precise control over venom delivery as is possible with front-fang snakes. Historically, many of these snakes were considered non-venomous. However, recent taxonomic revisions acknowledge that some species within this group are venomous. Some of these venomous species have caused human fatalities or significant envenomings. Within the scientific community, there is ongoing debate about the definition of venomousness. Some researchers advocate a broader concept that would include nearly all snakes, many lizard species, and other vertebrates, a view known as the toxicophora hypothesis. This broader definition is largely rejected by most toxinologists who maintain more specific criteria for what constitutes a venomous animal. The family Elapidae consists of a large and diverse group of exclusively venomous snakes. These snakes are found on all continents except Antarctica and in several major oceans. Elapids are characterized by well-developed fangs located towards the front of the mouth, which are capable of delivering highly potent venom produced in paired venom glands. A well-known example of an elapid is the Indian cobra, although not all cobras have the traditional hood. Other medically significant elapids include Australian death adders, Crites mambas, and taipans. These snakes can cause a range of effects from neurotoxic paralysis to local tissue injury, blood clotting disorders, muscle breakdown, and kidney damage. Sea snakes, which are also classified under the family Elapidae, belong specifically to the subfamily Hydrophini. Elapids are a major cause of snakebite-related sickness and death worldwide. In the United States, coral snakes, which belong to the genera Micrurus and Microroids, are examples of snakes in this family. These snakes are primarily known for producing neurotoxins that can cause symptoms such as blurred vision, abnormal sensations, drooping eyelids, paralysis, and respiratory failure. Unlike some other venomous snakes, coral snakes tend to cause less local tissue damage. The venom of the eastern coral snake, Micrurus fulvius, is particularly toxic in mice, mainly due to the presence of neurotoxic phospholipase A2 enzymes. The family Viperidae comprises a large and diverse group of exclusively venomous snakes found on most continents, with the exceptions of Australia, New Guinea, and Antarctica. These snakes are characterized by a highly developed fang structure, with fangs positioned at the front of the mouth. These fangs are attached to a mobile upper jawbone, allowing them to fold away when not in use, which facilitates the presence of longer fangs. Within this family, there are two main subfamilies. The first is the Old World vipers, which include species such as Russell's vipers from Asia and the puff adder from Africa. These vipers possess venom capable of causing severe local tissue damage, coagulopathy, hemorrhage, shock, and occasionally neurotoxicity. The second subfamily comprises the pit vipers, distinguished by their heat-sensitive pit organs located in front of their eyes. These structures enable them to detect prey effectively. This group includes rattlesnakes, cottonmouths, and copperheads. In terms of clinical significance, pit vipers are the leading cause of venomous snake bites in the United States, accounting for more than 98% of cases. Their venom is complex and often results in local inflammation and swelling, blood clotting issues such as coagulopathy and hemorrhage, and in some cases neurotoxic effects. Rattlesnakes tend to produce the most severe clinical symptoms among American pit vipers and are responsible for nearly all fatalities related to snake bites in the country. Copperheads are the most frequently implicated species, causing approximately 45 to 52% of bites annually. The composition, potency, and amount of venom produced by these snakes can vary significantly based on multiple factors, including the genus and species, age, diet, climate, season, and geographic location. Even among snakes of the same species living in the same area, venom characteristics can differ. For example, venom from Agkistrodon species demonstrates dynamic variation in anticoagulant effects, which can influence both the clinical presentation of envenomation and the effectiveness of antivenom treatment. Certain venoms contain high levels of metalloproteinases, enzymes that can cause tissue damage, but may have lower overall toxicity. Others may have lower metalloproteinase activity, but possess high toxicity, rich in phospholipase A2 neurotoxins, which can cause neurotoxic symptoms. The Lamprophidae family, specifically the subfamily Atractaspinae, consists of a small group of venomous snakes. These snakes are found exclusively in Africa and the Middle East. They are characterized by their side-striking fangs and unique venom components such as seraphotoxins. Only a few species within this subfamily are known to cause significant envenomation in humans. When envenomated, individuals may experience local effects, tissue necrosis, and cardiotoxicity. Medically important non-venomous snakes include several species that, while generally causing few problems, can pose significant risks. Large snakes, such as pythons and boas, which belong to the family Boidae, are capable of delivering substantial bites. Their long, sharp, recurved teeth can cause deep mechanical injuries and increase the risk of infection. These snakes can also constrict their victims by wrapping around the torso or neck, which can lead to crush injuries. Such constriction may result in internal organ damage and have lethal effects on the cardiovascular and respiratory systems. There is some controversy over whether pythons and boas produce toxins. However, this is not considered clinically relevant for human envenoming. Venomous snakes are considered the leading cause of significant illness and death among all terrestrial venomous and poisonous animals. While poisoning caused by marine animals can affect large populations, snakebites are the primary cause of death from venomous and poisonous animals across various environments. The global annual incidence of snakebites is estimated to be quite high, with some reports indicating up to 5,500,000 bites each year. Approximately 50% of these bites are caused by venomous snakes. Annual complications from snake bites include around 400,000 amputations and about 100,000 deaths worldwide. Different studies provide varying estimates. One suggests there are approximately 2,540,000 venomous snake bites annually, resulting in at least 125,000 deaths. Another estimate, employing different methodologies, indicates between 420,000 and 1,840,000 cases each year, with 20,000 to 94,000 fatalities. In India alone, detailed studies have determined that at least 45,500 people die each year from snake bites. This indicates that global estimates of deaths ranging from 20,000 to 94,000 are likely too conservative. A more realistic estimate of worldwide annual deaths due to snake bites is at least 100,000. Snake bites are among the top 10 to 15 most critical health issues in certain rural tropical regions. These high-risk areas often coincide with regions that lack adequate medical and financial resources, which results in higher fatality rates. Better access to modern medical care and antivenoms could significantly reduce these fatalities. Medically important snake species globally include several groups responsible for a high number of bites and fatalities each year. Saw-scaled or carpet vipers, belonging to the genus Echis, are found from West Africa across the Indian subcontinent and are estimated to cause over 100,000 bites and approximately 10,000 deaths annually. Russell's vipers, which include Deboia racilii and Deboia siamensis, are distributed from Sri Lanka throughout Southeast Asia. The puff, adder, and related species are common in many parts of Africa. Numerous cobra species are present in both Africa and Asia, while kite species are found from Sri Lanka to Southeast Asia. The Malayan pit viper is native to Southeast Asia, and various pit vipers belonging to the genera Trimeresurus and Gloideus are found in Asia. In the Americas, snakes from the genera Bothrops, Crotalus, and Agkistrodon pose significant health risks. Although Australian elipid snakes have a reputation for danger, they cause relatively few bites and result in very few deaths. Consequently, they are considered less significant from an epidemiological perspective. The United States is home to nearly 30 species and subspecies of venomous snakes. Most snake bites in the country occur between April and September, with the highest number of cases reported in July. Each year, approximately 5,000 to 9,000 people seek emergency medical care for bites from crotaline snakes, which are a group of vipers. Fortunately, fatalities from snake bites are rare in the United States, with fewer than 10 deaths reported annually. Almost all clinically significant snake bites in North America come from the Viperidae family, specifically the subfamily Crotalini, known as pit vipers. This group includes rattlesnakes, cottonmouths, and copperheads. Copperhead snakes are the most frequently involved in bite incidents, accounting for nearly half of reported cases each year. Rattlesnakes are widespread across most of the United States, especially in the western and southern regions. They are responsible for the majority of serious health issues and nearly all deaths resulting from snake bites in the country. A smaller percentage of native venomous snake bites are caused by snakes from the coral snake family. These include the Arizona or Sonoran coral snake, the Texas coral snake, and the eastern coral snake. Envenomations from coral snakes are relatively uncommon, and there are very few reports of such cases reaching poison control centers annually. Men make up approximately 75% of snakebite victims, while children account for about 10 to 15% of reported cases. Most bites occur on an extremity, although bites to the torso, face, and tongue also happen. Intentional interaction with snakes is a common factor in many cases. Bites often happen when individuals purposely handle a known venomous snake. Herpetologists who capture and study wild snakes, as well as religious snake handlers, are at the highest risk. Illegitimate snake bites caused by deliberate handling or provocation of a snake or by a captive snake pose a significant problem, especially in Western countries where hobbyists keep venomous snakes. These incidents frequently involve severe bites from exotic species for which appropriate antivenom may not be easily accessible. Sometimes, people are envenomed after killing and decapitating a rattlesnake, likely due to reflexes in the venom apparatus. Snake handlers and collectors are at risk of experiencing multiple bites. There is no convincing evidence that immunity develops from repeated envenomation. Instead, individuals who are bitten multiple times may have a higher risk of anaphylaxis due to prior sensitization. In the United States, approximately 30 to 50 bites from a wide variety of exotic venomous snakes are reported annually to poison control centers. The most common exotic snakes involved in these incidents belong to the family of vipers, accounting for 43% of bites, followed by snakes from the family of cobras, which are responsible for 39% of bites. These bites most often involve male owners who are bitten during activities such as feeding, handling, cleaning cages, or milking snakes for venom in private residences. Snake venoms are typically produced in specific venom glands that develop from salivary glands. An exception to this are the Duvernoy's glands, which are found in some non-front-fanged colubrid snakes. Once the venom is produced, it is delivered through a duct to the base of the fang. From there, it is transported into the victim either through a groove in the fong or via a dedicated fong duct. The process of venom ejection is often precisely controlled by the snake. This control is achieved through the contraction of muscles surrounding the venom gland, which increases intraglandular pressure and facilitates venom injection. This mechanism can explain the occurrence of what are known as dry bites, where a venomous snake bites but does not inject enough venom to cause significant medical symptoms. In contrast, snakes that possess Duvernoy's glands, such as some non-front fang species, may have less precise control over venom ejection. These glands operate under lower pressure compared to the high-pressure glands found in front-fanged venomous snakes like elapids and vipers. As a result, their venom delivery mechanisms can vary significantly, affecting the quantity of venom delivered during a bite. Snake venom is a complex mixture composed of proteins, peptides, lipids, carbohydrates, and metal ions. It contains a diverse array of enzymes, including phospholipases, A2 metalloproteinases, serine proteases, acetylcholinesterases, L-amino acid oxidases, and hyaluronidases. In addition to enzymatic components, non-enzymatic proteins also play significant roles. These include three-finger toxins, seraphotoxins, disintegrins, C-type, lectin-like proteins, bradykinin potentiating peptides, vascular endothelial growth factors, and cysteine-rich secretory proteins. The primary functions of snake venoms are the acquisition of prey and protection against predators, although a third function, which involves the predigestion of prey, has been suggested. This remains largely unproven. Snake venoms contain components that exert one or more distinct toxic actions. Many potent toxins have highly specific targets, such as the neuromuscular junction or components of the hemostatic system. Venom variability is a crucial concept in toxinology. The content and potency of venom in a given snake can vary significantly depending on factors such as age, diet, geographic location, and even season. This intraspecies and intra-individual variability means that venom from an adult snake may differ from that of a younger snake of the same species. This can lead to marked regional variation in venom activity to the extent that anti-venom developed using venom from one geographic area may be ineffective against bites from the same species in another area. Classic examples include Russell's viper, Deboia russellii/siamensis, and the South American rattlesnake, Crotalus durissus terrificus. Even within a single geographic location, distinct venom types may exist among subpopulations. When venom is injected, usually subcutaneously, locally acting toxins exert immediate effects. A significant portion of the venom may be transported via the lymphatic system before entering the circulation, which explains findings like enlarged or tender lymph nodes and the potential for prolonged venom release from a local depot. Toxins targeting hemostasis or causing hemorrhage and nephrotoxins can quickly reach their targets once in circulation. However, toxins like neurotoxins and myotoxins, which target extravascular sites, may have a delayed onset of clinically detectable action. Snake venoms typically cause a wide range of clinical effects, which can be broadly classified based on their primary toxic activity. One major group is neurotoxins, which are diverse polypeptide toxins that primarily cause flaccid paralysis by acting at the neuromuscular junction. These neurotoxins can be categorized further into presynaptic and postsynaptic types. Presynaptic neurotoxins, found in snakes such as the Australian and New Guinea death adders, krites, mambas, tiger snakes, taipans, certain rattlesnakes, and European vipers, inhibit the release of the neurotransmitter acetylcholine presynaptically. These toxins are resistant to late anti-venom therapy. An example of a presynaptic neurotoxin is Mojave toxin, a phospholipase A2 enzyme present in some populations of Mojave rattlesnakes. In contrast, postsynaptic neurotoxins, which are found in snakes, such as the small-eyed snake in New Guinea, American coral snakes, some cobras, king cobras, and sea snakes, antagonize nicotinic acetylcholine receptors at the postsynaptic level. These toxins are often reversible with anti-venom therapy. The toxicity of coral snake venom is mainly due to neurotoxic phospholipase 2 enzymes. Clinically, neurotoxicity can manifest as blurred vision, paresthesias, drooping eyelids, paralysis, and in severe cases, respiratory failure, which can be fatal, especially in regions lacking adequate intensive care facilities. Another significant group of toxins are myotoxins, which cause local muscle damage at the site of the bite and can lead to systemic muscle breakdown or myolysis. The systemic effects include muscle pain, tenderness, weakness, and myoglobinuria, which presents as red or muddy brown urine. Myotoxic enzymes, particularly phospholipase A2 enzymes, play a crucial role in causing muscle tissue destruction and systemic symptoms. Toxins that affect blood clotting, known as hemotoxins, are found in various venoms which contain a complex mixture of components that interfere with the body's hemostasis process. These components include substances that promote clotting, inhibit clotting, and promote fibrinolysis. Procoagulants such as enzymes that activate factors 5, 9, and 10, as well as prothrombin and fibrinogen, can lead to a consumption coagulopathy, a condition where clotting factors are depleted. Anticoagulants, including proteins that activate protein C, factors 9 and 10, thrombin inhibitors, and certain phospholipase A2 enzymes, disrupt the clotting cascade, preventing proper blood coagulation. Fibrinolytic agents promote the breakdown of fibrin or fibrinogen or activate plasminogen, leading to the dissolution of blood clots. Many viper species produce toxins that affect blood coagulation, often resulting in coagulopathy and hemorrhage. In contrast, only a few species of elipid snakes, mainly those found in Australia and New Guinea, cause similar effects. In North America, envenomation from venomous snakes of the rattlesnake family often results in anticoagulant effects. Thrombin-like enzymes and fibrinogen-degrading enzymes play a significant role as they cleave fibrinogen and produce clots that are poorly cross-linked and easily broken down. Variations in venom composition among species of the genus Adcastrodon influence their anticoagulant effects, which can affect clotting times, fibrinogen levels, and clot strength. Some venoms directly damage fibrinogen, leading to weak and unstable clots, while others activate endogenous anticoagulant enzymes such as protein C. These effects can vary even within the same species, complicating diagnosis and treatment. Consequently, there is a need for broad-spectrum antivenoms capable of neutralizing diverse venom components. Hemorrhagens are another class of toxins, generally zinc metalloproteinases, that directly damage the lining of blood vessels, promoting bleeding. These toxins can be potentially lethal due to their destructive effects on vascular integrity. Nephrotoxins are substances that can cause kidney damage. While secondary renal damage is common in snakebite cases, only a few snake species produce direct nephrotoxins. Necrotoxins are a type of toxin that causes local tissue injury and tissue death around the bite site. These toxins are commonly found in bites from vipers, but some cobras from Africa and Southeast Asia can also produce them. Phospholipase A2 toxins are believed to play a significant role in this tissue damage. Snake venoms contain many other components, and their clinical effects are often not well understood. For example, disintegrins and C-type lectin-like proteins can affect platelets, influencing blood clotting and other related processes. The clinical presentation of envenoming is highly variable and depends on several factors. These include the species of the snake, the amount and potency of venom injected, the location of the bite, and patient-specific factors such as age, size, health, and previous exposure to venom. For example, venom from North American pit vipers can simultaneously damage tissue, affect blood vessels and blood, and alter neuromuscular transmission. Copperhead envenomations are generally less severe in terms of blood-related effects compared to other crotaline envenomations. However, there can be significant individual variations in the severity of symptoms. When a venomous snake bites, venom is usually injected beneath the skin, directly at the site where local toxins act. This close proximity to the tissues allows the toxins to begin affecting the body quickly. The clinical effects of envenoming can vary widely. Factors influencing the severity and presentation include the species of snake, the amount of venom injected, and the potency of that venom. Additionally, the location of the bite and individual patient factors such as age, size, and overall health play significant roles in the clinical outcome. Following envenomation, several local effects are commonly observed. One of the characteristic features is local swelling or edema, which often progresses rapidly. The speed and extent of swelling can help indicate the probable severity of the envenoming, especially with venoms that are locally active, such as those from many viperid species. Sometimes, swelling may be delayed by 8 to 12 hours before becoming noticeable. Erythema or redness is another common sign. Bruising and discoloration, known as ecchymosis, may occur, and in cases of bites on the foot, the entire dorsal aspect of the foot might appear bluish. Hemorrhage or bleeding can also be observed, along with blistering, which involves the formation of fluid-filled blisters, sometimes hemorrhagic in nature. In some cases, tissue death or necrosis can develop at the bite site. This is a typical feature of viperid bites, although not all vipers cause local necrosis. Certain elipid snakes, particularly some species of cobra from Africa and Southeast Asia, can also routinely lead to local tissue necrosis. Pain at the bite site is a frequent symptom. However, its variability means it is not always a reliable indicator of significant envenoming. Additionally, some envenomations from the Texas coral snake may be characterized by painful sensations known as paresthesias. It is important to recognize that fong marks are almost always present in snakebite cases. These marks usually appear as 1 or 2 puncture wounds, small lacerations, or scratches. However, they can sometimes be very small or absent entirely, especially in cases involving colubrids and smaller elipids. In many patients, it may be possible to observe a small drop of blood at the bite site. Despite this, the absence of a local reaction should never be automatically interpreted as a trivial bite. This is particularly true unless the species of snake is known to cause only minor local effects in all medically significant cases. For example, local swelling may be absent after bites from many elipid snakes. Envenomation by coral snakes generally results in minimal local signs or mild swelling, especially when compared to bites from pit vipers. Different snake families and species are associated with varying degrees and types of local effects. Viperids and crotalids are well known for causing significant local tissue injury and necrosis. African bush vipers belonging to the genus Atheris may cause minimal effects. In contrast, some African puff adders and Gaboon vipers, both of the genus Bitis, can cause severe local tissue injury. African night adders from the genus Causis and African horned adders from the genus Erastes tend to cause local effects as well. North American pit vipers, which include species from the genera Agkistrodon, Bothrops, and Crotalus, frequently cause local effects such as necrosis, coagulopathy, and hemorrhage. Envenomation by copperhead snakes, a species within this group, is often limited mainly to the progression of tissue damage. In North American crotaline envenomation, common local effects include tissue damage, swelling, bruising, redness, hemorrhagic blisters, and skin necrosis. Asian terrestrial pit vipers, such as those of the genus Gloideus, Sri Lankan hump-nosed vipers of the genus Hypnail, Central and South American bushmasters of the genus Lachesis, Central American horned pit vipers of the genus Ophryagus, Asian montane pit vipers of the genus Oviphis, and Central American montane vipers of the genus Perthidium, are also known to cause local effects, often including necrosis or shock. North American pygmy rattlesnakes and Massasauga, classified under the genus Cestruris, tend to cause local effects and necrosis, with hemorrhage being a rare occurrence. Asian green pit vipers, belonging to the genus Trimeresurus, and Asian tree vipers of the genus Tropidolaemus, generally cause local effects. However, necrosis, coagulopathy, and hemorrhage are rarely seen with bites from these species. Elipids are a diverse group of snakes, often associated with neurotoxicity. However, some species can cause severe local effects. For example, African garter snakes belonging to the genus Ellipsoidea mainly cause local effects without significant systemic impact. The African rinkhouse or spitting cobra, known scientifically as Hemicadus hemicadus, can induce local tissue injury upon bite. African and Asian cobras classified under the genus Naja vary in their effects depending on the species. Some can cause severe damage to local tissues and may also induce paralysis due to neurotoxicity. The new Guinea small-eyed snake, Micropechis ikehika, has the potential to cause muscle tissue breakdown, known as myolysis. North American coral snakes of the genus Micrurus are primarily recognized for their neurotoxic venom. They typically do not cause significant local tissue effects, although some bites may result in mild swelling and tingling sensations around the bite site. Local tissue damage resulting from venom exposure is a complex process involving multiple components of the venom. Key contributors include metalloproteinases, which are enzymes that promote inflammation, proteolysis, and hemorrhage. They damage the vascular endothelium, increasing vascular permeability, which leads to the leakage of plasma and blood. This leakage manifests as tissue swelling and bruising, and these enzymes also directly cause skin tissue necrosis. Hyaluronidase is another enzyme that facilitates the spread of venom through tissues by breaking down the extracellular matrix and basement membranes around small blood vessels, thereby contributing to swelling. Phospholipases, A2, are enzymes believed to play a significant role in local tissue damage and cell death, particularly in the muscles. In some snake species, such as North American rattlesnakes, these enzymes cause injury around the bite site without necessarily leading to widespread muscle breakdown, although they can cause damage to muscle tissue directly. Serine proteinases may contribute to inflammation by activating tissue-degrading enzymes naturally present in the body. The combined effects of these toxins and the body's inflammatory response can ultimately damage the basement membrane of capillaries, resulting in swelling and bruising. Some hemorrhagic metalloproteinases, even in the absence of blood clotting disorders or low platelet counts, can cause significant bleeding under the skin. Assessment of local signs is essential for determining the extent of envenoming. Clinicians examine the bite site for various signs. They look for puncture marks, lacerations, or scratches. Swelling is also a crucial indicator. The speed at which swelling occurs and its size can help determine the severity of envenoming. Persistent extravasation of venom may lead to complications such as anemia, decreased blood volume, and low blood pressure. Additionally, clinicians observe for bruising, discoloration, blistering, and signs of developing necrosis around the bite area. Pain and tenderness are common symptoms, and these sensations can extend along the lymphatic pathways even before swelling progresses proximally. Enlarged or tender lymph nodes near the bite site are also frequently noted during clinical examinations. Upon presentation of a suspected snakebite, healthcare professionals, including pharmacists involved in clinical decision-making, must consider three fundamental questions. First, they need to determine whether the condition is truly a snakebite or if it is another medical issue that appears similar. If it is confirmed to be a snakebite, the next step is to assess whether significant envenoming has occurred and to evaluate its severity. Finally, it is important to identify the specific type of snake responsible for the bite. Addressing these key questions is crucial for ensuring appropriate treatment and management of the patient. Laboratory tests are invaluable tools for determining the extent of envenoming and monitoring the effectiveness of treatment. Even in small or rural hospitals without access to comprehensive laboratory facilities, some essential tests can still be performed. One such test is urinalysis, which helps detect the presence of hemoglobin or myoglobin in the urine, both of which indicate blood presence. Microscopic examination can further help differentiate between hemoglobinuria and myoglobinuria by identifying red blood cells or casts in the urine. Another important bedside test is the whole blood clotting time, along with the 20-minute whole blood clotting test. These straightforward tests are crucial indicators of coagulopathy, a condition where the blood's ability to clot is impaired. If the blood fails to clot or forms only a weak clot within 15 to 20 minutes, it suggests that coagulopathy is likely present. The 20-minute whole blood clotting test is a validated and widely used method, especially in settings where formal coagulation testing is unavailable. When full laboratory facilities are available, several urgent tests should be performed for patients envenomated by snakes, especially in regional or teaching hospitals. These include extended coagulation studies, which assess the blood's ability to clot properly. Such studies should include tests for prothrombin time, international normalized ratio, activated partial thromboplastin time, fibrinogen levels, and the presence of cross-linked or D-dimer degradation products of fibrin and fibrinogen. Coagulation disturbances like thrombocytopenia, hypofibrinogenemia, and elevated clotting times are common hematologic effects seen in envenomation by Crotolini snakes. A complete blood count is also essential, particularly focusing on platelet counts and absolute lymphocyte counts. Thrombocytopenia, defined as a platelet count less than 120,000 per cubic millimeter, frequently occurs in such cases. Additionally, it is important to evaluate electrolytes, urea, and creatinine levels to assess renal function and identify any electrolyte imbalances, especially in cases involving muscle breakdown. Measuring creatinine phosphokinase can help detect muscle damage resulting from the envenomation. Where appropriate, arterial blood gas analysis should be conducted to assess the patient's respiratory and metabolic status. A peripheral blood smear examination may be useful to identify microangiopathic hemolysis, which could indicate the presence of disseminated intravascular coagulation. However, it is important to note that venom-induced thrombocytopenia and coagulation abnormalities typically do not signify disseminated intravascular coagulation. Snake venom detection kits are specialized tools used to identify venom from snake bites. Currently, the only commercial system available is the Australian CSL Snake Venom Detection Kit, which employs a sensitive technique called sandwich enzyme-linked immunosorbent assay. This assay can detect nanogram concentrations of venom, but it is only applicable for snakes native to Australia and New Guinea. The most effective sample for testing is a moist swab taken from the bite site. If the bite site is unavailable, urine can be used as an alternative sample. Blood samples are considered less reliable for detection purposes. The kit provides a qualitative result, which indicates the immunotype of the venom. This information helps guide the appropriate use of specific antivenoms rather than generic polyvalent antivenoms. However, it is important to note that a negative result from the test does not necessarily rule out envenoming. Conversely, a positive result does not always mean that there is significant envenoming or that antivenom treatment is needed. In North America, laboratory tests that directly detect venom in wounds are not currently available for early diagnosis or clinical management. However, enzyme-linked immunosorbent assay tests can measure venom antigen levels in blood and urine in research settings. Globally, there are experimental systems for detecting venom, and these have the potential to become commercially available in the future. Such advancements could lead to more precise guidelines for dosing antivenom. Snake envenomation is a complex process, and the initial findings may not reflect the full extent of the problem. It's crucial to repeat tests, even if the first results are normal, to detect any late development of envenoming, especially coagulopathy. For instance, if the initial examination and tests are normal, retesting is advised at 2 hours, then again 3 hours later, 5th hour after the initial assessment. In some cases of copperhead envenomation, patients can experience delayed onset of symptoms for up to 8 to 10 hours. If there's no initial swelling or other signs of envenomation, it's recommended to observe the patient for 8 hours after an Agkistrodon bite and 12 hours after a rattlesnake bite. If there's no swelling and lab studies remain normal and unchanged after at least 8 hours, a dry bite is likely and the patient can be discharged. Similarly, certain systemic effects like coagulopathy can persist, develop late, or recur, requiring retesting over several days, especially after certain viper bites. Diagnosing snake bites presents several challenges and nuances. One common issue is the occurrence of dry bites where no venom is injected during the bite. Approximately 20 to 25% of pit viper bites fall into this category. Determining whether a bite was dry or venomous is difficult without extended observation, as symptoms of envenomation can be delayed. The clinical presentation of snake bites varies widely based on several factors. These include the species of snake involved, the amount and potency of venom delivered, the location of the bite, and individual patient factors. Even within the same species, or over different periods, the variability in venom composition can lead to different clinical effects. Identifying the snake responsible for the bite is often a challenge. Sometimes the victim is unable to recall or describe the snake accurately. Visual descriptions tend to be unreliable, and attempting to capture or kill the snake is generally discouraged due to safety concerns. In some regions, such as Australia, venom detection kits are available to assist with identification. However, these are not universally accessible. Frequently, the most effective approach involves considering the geographic location, combined with local and systemic effects observed in the patient, guided by regional studies. Symptoms of envenomation may not always be specific. General symptoms such as headache, nausea, vomiting, and abdominal pain can occur. These symptoms might also stem from anxiety related to the bite, making it essential to differentiate true envenoming from psychological responses. Correct diagnosis is particularly important when deciding whether to administer antivenom. Furthermore, the absence of local signs such as bite marks or tissue swelling does not necessarily indicate the absence of significant envenomation. Certain types of venom, especially from some elipid snakes, can cause serious blood abnormalities like low platelet counts or clotting issues without producing noticeable swelling or tissue response. Therefore, clinical assessment must consider these factors to ensure accurate diagnosis and appropriate treatment. The only universally approved first aid treatment for snakebite, applicable worldwide, is to immobilize the bitten area or limb and keep the victim as still as possible. Although this method has not been proven through clinical trials, it is supported by extensive anecdotal evidence. For patients who experience systemic effects such as diarrhea or weakness, administering intravenous fluids before reaching a hospital can be beneficial. Additionally, pain relief medications are recommended for severe pain, especially if there's a delay in transporting the victim to a medical facility. For bites by species that do not cause necrosis, including many elipids though not most cobras, and some vipers, the pressure immobilization method developed in Australia is regarded as both safe and effective. This technique works by slowing down the transport of venom through the lymphatic system. It involves applying moderate local pressure and limb compression to block superficial lymphatic vessels, while immobilizing the limb in a splint to inhibit the muscle pump mechanism responsible for venom movement. When applied correctly, the pressure immobilization method can be safely left in place for several hours. Experimental evidence suggests that it is as effective as using a tourniquet to prevent venom spread, but it is significantly safer. Recent research indicates that elasticized bandages may be more effective than crepe bandages in achieving proper compression. There is also promising progress in adapting this technique for broader use. In Myanmar, a modification that employs a pressure pad over the bite site has shown potential in treating viper bites without increasing tissue injury. If further studies confirm these findings, such modifications could extend the applicability of pressure immobilization techniques to all snake bites. However, full acceptance of this method worldwide remains limited due to concerns that targeting necrotic venom might exacerbate local tissue damage. Beyond immobilization techniques, general wound care involves gently cleaning the bite area unless venom detection tests are available, as is the case in Australia and New Guinea. It is advisable to give clear fluids orally, but food and alcohol should be avoided. The most crucial step is to ensure rapid transportation to a medical facility capable of administering antivenom and providing appropriate treatment. North American pit vipers, such as rattlesnakes, copperheads, and cottonmouths, should not be treated with pressure immobilization bandages. Research, including studies using a pig model, has demonstrated that these bandages can significantly raise pressure within the affected limb and cause tissue death, which is particularly problematic given the significant local tissue injury associated with these bites. Several professional organizations, including the American College of Medical Toxicology, recommend against using pressure immobilization for these envenomations. Instead, pre-hospital care should focus on immobilizing the affected limb, establishing intravenous access, treating any life-threatening conditions, and ensuring rapid transportation to a medical facility. In contrast, pressure immobilization can be considered for bites from North American coral snakes, especially if hospital transport will take a prolonged period. Unlike pit viper bites, coral snake venom primarily causes neurological symptoms without extensive local tissue damage. Applying a pressure immobilization bandage in this case can slow the systemic absorption of venom, a practice similar to approaches used with Australian venomous snakes. If such a bandage is applied, it should remain in place until resuscitation equipment and medical personnel are available, and ideally when antivenom is ready for use. It is crucial that the bandage does not function as a tourniquet, as this could worsen outcomes. Many traditional or previously advocated first aid measures are no longer recommended because they are ineffective, potentially harmful, or could delay obtaining proper medical care. For instance, using a tourniquet is discouraged because it can be misused easily, only effective for a short period, and carries a significant risk of severe injury through tissue death caused by lack of blood flow. This can lead to gangrene and the possible amputation of the affected limb. Applying suction to the bite site, whether by mouth or mechanical devices, is unsuitable. Mouth suction risks transferring venom into the oral cavity and introducing bacteria into the wound. Dedicated suction kits remove only tiny amounts of venom and may damage local tissues, which could facilitate the spread and absorption of venom. Cutting into the wound or removing tissue is also discouraged, as it can cause additional injury, increase the absorption of venom, and may lead to severe bleeding if blood clotting problems are present. Using local electric shocks has never demonstrated any benefit in scientific studies or clinical trials and is therefore regarded as a discredited practice. Applying ice or cold therapy to the bite area, known as cryotherapy, is unnecessary and can cause tissue damage. The use of topical agents such as medications to reduce lymphatic flow, like nifedipine or lignocaine, has been proposed based on animal studies, but lacks confirmation from human research and cannot be recommended. Finally, traditional healing practices, such as the use of snake stones, have no scientific basis. Although some native plant extracts might prove beneficial in the future, they cannot be recommended at this time until their safety and efficacy are conclusively demonstrated. Upon a patient's arrival at a medical facility, the immediate priority is to critically assess and stabilize vital systems. This involves a swift evaluation and management of the airway, breathing, and circulation, which are paramount in any critical care scenario. For patients experiencing respiratory distress, such as rapid breathing or low oxygen saturation, oxygen supplementation should be initiated. This can be achieved using devices like a non-rebreather mask or bilevel positive airway pressure. If the patient's respiratory status does not improve or if signs of impending respiratory failure or bulbar paralysis develop, particularly in cases of coral snake envenomation, preparations for endotracheal intubation should be made. Early and aggressive airway management, along with ventilatory support, are essential to prevent complications such as aspiration pneumonia. Regarding circulatory support, an intravenous line should be established and, in most cases, an initial intravenous fluid load should be administered. This is especially important if there is a significant local reaction leading to fluid shifts and potential hypovolemic shock. The choice of intravenous fluids depends on the circumstances and what is available. For patients at risk of developing blood clotting problems requiring repeated assessment, it is advisable to consider a line that allows for multiple blood samples to minimize the need for numerous venipunctures. Venipunctures should avoid femoral, jugular, and subclavian veins due to the risk of bleeding complications. Regular monitoring of pulse, blood pressure, and cardiac rhythms is essential, preferably with appropriate monitoring equipment. If blood clotting issues are suspected, cardiac compressions should be performed cautiously and only if absolutely necessary. Pain management should involve the use of opioids because there is a theoretical risk that nonsteroidal anti-inflammatory drugs may worsen blood-related toxicity. Although recent discussions have questioned this practice, opioids remain the standard treatment for managing acute pain in envenomation cases. Wound care involves gentle cleaning of the bite area. If tense blisters are present, debridement of the wound is indicated. Tetanus immunization status should be assessed and updated as soon as it is safe to do so. Intramuscular tetanus boosters should be avoided in patients with blood clotting issues to prevent serious hematomas. Immobilization and elevation of the bitten limb are important steps in the initial management. The affected limb should be immobilized using a padded splint positioned near full extension. Elevating the limb above the level of the heart is also recommended, as this can help decrease dependent edema, reduce pain, and prevent the limb from being held in a flex position. Patients should be continuously monitored for signs of envenomation progression. Regular assessments are necessary to check for the development of paralysis, coagulopathy, muscle breakdown, or kidney failure, even if the patient initially shows no symptoms. It is crucial to mark the edges of tenderness, redness, and swelling, and to reassess these markings every 15 to 30 minutes to track local tissue changes. Patients should also be asked about increasing pain or changes along the lymphatic pathways. Monitoring urine output is essential, and in some cases, inserting a urinary catheter may be considered, especially in adults. However, caution is advised to avoid trauma from insertion, particularly if coagulopathy is present. An observation period of 8 to 12 hours should be maintained for patients with puncture wounds who do not initially show swelling or other signs of envenomation, as symptoms may be delayed. In the intricate landscape of snakebite management, antivenom therapy is the definitive and only specific treatment for envenomation. This critical aspect is essential for pharmacists to master in their clinical practice. The efficacy and safety of antivenom have transformed snakebite care from a high-mortality scenario to one primarily focused on managing morbidity. Hospital treatment is the cornerstone of snakebite management in regions where effective care is accessible. When a patient presents with a snakebite, the immediate priorities include critically assessing and stabilizing vital systems, with particular attention to the airway, breathing, and circulation. This foundational supportive care sets the stage for specific interventions, such as the administration of antivenom. It is advisable to establish intravenous access in an unaffected limb and minimize venipunctures, avoiding veins in the femoral, jugular, or subclavian regions due to the potential risk of bleeding associated with coagulopathy. Regular monitoring of vital signs, including pulse rate, blood pressure, respiration, and cardiac rhythms, is essential. North America is home to over 30 species and subspecies of venomous snakes, with the majority of human envenomations in the United States caused by the subfamily of snakes commonly known as pit vipers. This group includes rattlesnakes, cottonmouths, and copperheads, each belonging to different genera. Envenomation by snakes in this group is characterized mainly by local swelling and tissue damage caused by cytotoxic effects, along with common effects on the blood. There is also a potential for systemic illness and neurotoxicity in some cases. Rattlesnake bites tend to produce the most severe clinical symptoms, followed by cottonmouths and then copperheads, although even bites from copperheads can be serious and potentially life-threatening if anaphylaxis occurs. The venom of these snakes is a complex mixture of proteins and peptides that act on various organs and tissues. Components such as metalloproteinases, serine proteases, and phospholipids A2 cause inflammation, damage to small blood vessels, and bleeding. The composition of venom can vary depending on the species, the age and diet of the snake, environmental factors such as climate, and even different geographic locations within the same species. Antivenom is considered the only specific therapy for snake envenomation. Its primary mechanism involves binding to venom antigens, neutralizing their toxic effects, and facilitating their elimination from the body. While antivenom can halt tissue damage and reverse some effects such as coagulopathy, it generally cannot reverse pre-existing tissue injury. Despite the potential cost and risk of adverse reactions, the danger of untreated envenomation usually outweighs the risks associated with antivenom administration. Therefore, antivenom should never be withheld from a patient who needs it. Antivenom is considered the only specific therapy for envenomation. Its primary mechanism involves binding to and neutralizing venom antigens, thereby preventing their toxic effects and enhancing their elimination from the body. It can halt the progression of tissue damage and reverse certain venom effects like coagulopathy, but it generally does not reverse existing tissue injury. Despite the financial burden and potential for adverse reactions, the risk of untreated envenomation is typically far greater than the risk of antivenom reactions, meaning antivenom should never be withheld from a patient who needs it. Currently, there are 2 antivenoms approved by the Food and Drug Administration for the treatment of envenomation caused by North American pit vipers. One of these is called Crotality Polyvalent Immune Feline, marketed under the name Crofab. This particular antivenom is derived from sheep. It is produced by immunizing sheep with venoms from 4 specific North American pit viper species: the eastern diamondback rattlesnake, the western diamondback rattlesnake, the Mojave rattlesnake, and the cottonmouth or water moccasin. The antibodies produced in these sheep are of the IgG type. These antibodies are then treated with an enzyme called papain, which breaks them down into Fab fragments. These fragments retain their ability to bind to venom antigens, but lack certain regions that can increase immune response, thereby reducing their immunogenicity. Additionally, an affinity purification process is used to remove nonspecific antibodies, making the antivenom more targeted and effective. This antivenom is approved for use in managing envenomations from all North American pit viper species, including those from the rattlesnake, cottonmouth, and copperhead snakes. Crofab is supplied as a lyophilized powder that requires reconstitution before use. Each vial should be reconstituted with 20 to 25 milliliters of a 0.9% sodium chloride solution, or until the vial is filled. The vial should be gently hand-rolled for approximately 1 minute to ensure the solution dissolves completely and to minimize foaming. Once reconstituted, the antivenom should be further diluted into a final volume of 250 milliliters of 0.9% saline. For initial infusion, it is recommended to administer the first dose cautiously at an escalating rate to minimize the risk of serious adverse reactions. The initial rate should be 10 milliliters per hour for the first 5 minutes, with close monitoring for hypersensitivity reactions. If the patient tolerates this dose well, the infusion rate can be doubled every few minutes to complete the first dose over approximately 1 hour. If the patient has tolerated the initial dose without issues, subsequent doses can be infused at a rate of 250 milliliters per hour without further rate titration. Regarding initial dosing, the manufacturer recommends administering 4 to 6 vials initially. However, an evidence-based consensus suggests that 8 to 12 vials may be appropriate for patients presenting with shock or active severe bleeding. Additional 4 to 6 vial doses may be given as needed until initial control of envenomation effects is achieved. Initial control is defined as the cessation of local tissue venom effects, a clear trend toward improvement in blood-related effects, and the resolution of systemic signs. It is important to set realistic expectations because complete resolution of hypofibrinogenemia can take several hours. Additionally, local findings such as hemorrhagic blisters or bruising may continue to worsen for days despite adequate antivenom treatment. Neurotoxic effects can also respond variably to antivenom therapy. Once initial control of envenomation is achieved, maintenance doses of 2 vials every 6 hours for 3 doses are recommended according to manufacturer guidelines. This amounts to a total of 6 additional vials over 18 hours. The purpose of this dosing strategy is to prevent the recurrence of local manifestations, thrombocytopenia, and coagulopathy, which can occur due to the shorter half-life of Fab antivenom compared to venom. However, not all practitioners routinely administer maintenance doses. In cases such as copperhead snake envenomations, regional variations in venom potency exist, and the severity of hematologic toxicity may be less. Therefore, some clinicians opt for an alternative approach. This alternative involves monitoring the patient over the 18-hour maintenance period and administering additional antivenom only if there is a progression of local tissue effects, persistent or worsening blood toxicity, or systemic signs of envenomation. A retrospective study comparing this as-needed approach with maintenance dosing found that the as-needed strategy used fewer vials, with a median of 8 versus 16, and resulted in a shorter hospital stay, with a median of 27 hours compared to 34 hours. Importantly, there were no significant differences in follow-up outcomes such as readmission, retreatment, bleeding complications, or surgical interventions. This challenges the rationale that maintenance dosing is necessary to prevent recurrent blood toxicity. These findings underscore the importance of frequent bedside reassessment by a medical toxicologist or an experienced clinician when adopting an as-needed dosing strategy. Crotality Immune F equine, marketed under the name Anavip, is an antivenom derived from horses. It is produced by immunizing horses with venoms from 2 South American pit viper species, Bothrops asper, commonly known as fer-de-lance, and Crotalus durissus, known as the Central American rattlesnake. Although the FDA-approved indication specifically refers to Crotalus durissus, the antivenom is effective against envenomation from both species. The antibodies extracted from the horses are treated with the enzyme pepsin to produce F-ub fragments. These fragments lack the Fc region but retain their hinge area, which provides 2 sites for antigen binding and results in a longer half-life compared to Fab fragments. Anavip received FDA approval in 2015 and became available commercially in the United States in October 2018. In 2021, its FDA approval was expanded to include envenomations caused by species within the Agkistrodon genus, such as copperheads and cottonmouths. This antivenom is approved for the treatment of both adult and pediatric patients bitten by North American pit vipers, including rattlesnakes, copperheads, and cottonmouths. The recommended initial dose is 10 vials, which can be repeated as necessary to achieve initial clinical control of symptoms. Once control is established, vials are administered as needed during an observation period of 18 hours. Anavip has been specifically engineered to reduce the risk of reemergent venom effects thanks to its longer half-life. Clinical trials have shown that no patients required retreatment for late venom effects, and the rates of late coagulopathy and low platelet counts were significantly lower, ranging from 5 to 10% compared to the earlier Fab antivenom, which had rates around 30%. Pregnant patients face limited information regarding snake bites from coral snakes and rattlesnakes. Snake venom can be hazardous to both the mother and the developing fetus, and even if the mother recovers well, adverse outcomes for the fetus can still occur. Consequently, the criteria for administering antivenom to pregnant women should align with those for non-pregnant individuals. In pediatric patients, children should receive the same dosage of antivenom as adults. Complications associated with antivenom therapy can be broadly categorized into immediate and delayed reactions, along with other significant considerations. Immediate adverse effects, also known as acute hypersensitivity reactions, typically occur during or shortly after infusion. These reactions include a rash, which is the most frequent and can sometimes herald anaphylaxis, itching, hives, angioedema, bronchospasm, low blood pressure, and severe reactions such as anaphylactic or anaphylactoid shock. Although these severe reactions are rare, especially when using high-quality antivenoms, likely occurring in less than 1% of cases, they can be fatal. Historically, some older products, particularly those containing unrefined immunoglobulin G, had reaction rates exceeding 80%. Other immediate adverse effects include fever caused by the biological toxin and symptoms such as nausea and vomiting. Recent research highlights a correlation between allergic hypersensitivity reactions to antivenom and alpha-gal syndrome, particularly with products derived from horses. Both FabAV, which is derived from sheep, and Fab2AV, derived from horses, contain the oligosaccharide galactose, alpha-1,3-galactose, which can trigger allergic reactions in individuals with alpha-gal syndrome. This syndrome is acquired through tick bites. A study from the Toxic North American Snakebite Registry found that allergic hypersensitivity reactions were more common with Fab2AV, occurring in 6.6% of cases compared to 2.9% with FabAV overall. The difference was especially notable in states where alpha-gal syndrome is more prevalent, with reaction rates of 22.2% for Fab2AV versus 3.3% for FabAV. The manufacturing process of Fab2AV involves pepsin digestion, which might not break down the alpha-gal oligosaccharide, potentially contributing to a higher reactivity. Additionally, higher initial doses of the medication, such as 10 vials for Fab2AV compared to 4 to 6 vials for FabAV, may also increase the incidence of allergic reactions, especially in regions with a higher prevalence of alpha-gal syndrome. This suggests that considering lower off-label doses for less severe cases might help reduce the likelihood of adverse reactions. It is important to note that allergic hypersensitivity reactions can occur on a person's first exposure to the antivenom and are not always mediated by immunoglobulin E antibodies, making them unpredictable and challenging to anticipate. Management of hypersensitivity reactions related to antivenom involves immediate discontinuation of the infusion if an adverse reaction occurs. Treatment includes administering epinephrine through intravenous infusion, subcutaneous, or intramuscular routes, along with providing oxygen and intravenous fluids. Antihistamines such as diphenhydramine and histamine H2 blockers, as well as corticosteroids like methylprednisolone, are also used. Once the reaction is under control, the antivenom infusion can be cautiously resumed, with dose adjustments guided by the patient's response to epinephrine. Pretreatment with antihistamines or corticosteroids has not shown consistent benefit. However, in settings with limited resources and high rates of adverse reactions to antivenoms, premedication with epinephrine administered under the skin may be considered. It is important to note that testing for allergy to antivenom before use is unreliable and not recommended. Delayed adverse effects such as serum sickness are a type of immune complex hypersensitivity reaction. They typically occur 4 to 14 or more days after the administration of antivenom, although in some cases, symptoms can appear as early as 3 days or as late as 3 weeks. This condition is characterized by the appearance of a rash, joint pains, fever, and a general feeling of malaise. In more severe, but less common cases, complications such as glomerulonephritis, vasculitis, myocarditis, and neuritis may develop. The risk of serum sickness is related to the total amount of foreign protein introduced into the patient, which depends on the number of antivenom vials administered. Treatment usually involves corticosteroids such as oral prednisone, which are tapered over a period of 2 to 3 weeks. Antihistamines may also be used to help alleviate symptoms. Despite the potential for serum sickness, the overall risk is significantly lower than the risk associated with untreated envenomation. Therefore, antivenom should never be withheld out of concern for adverse immune reactions. Recurrent or late hematologic toxicity is a significant complication, especially in cases of crotaline envenomation. It can manifest as the recurrence or delayed onset of coagulopathy, such as low fibrinogen levels, prolonged prothrombin time or international normalized ratio, activated partial thromboplastin time, or thrombocytopenia weeks after initial treatment. This issue can be associated with life-threatening bleeding. The phenomenon is attributed to differences in the pharmacokinetics of venom and antivenom. Specifically, the clearer rate of Fab antivenom compared to venom, as well as the delayed absorption of venom from tissue depots and the dissociation of venom-antivenom complexes contribute to these recurrences. To prevent such recurrences, maintenance doses of antivenom are recommended, such as administering 2 vials of Fab antivenom every 6 hours for 3 doses. Despite this, recurrences can still occur even in patients receiving maintenance doses. It is crucial to conduct careful outpatient follow-up with serial testing of platelet counts and coagulation parameters. For rattlesnake bites, follow-up testing should be done 2 to 3 days and 5 to 7 days after the last dose of antivenom. Copperhead bites, which are less likely to cause severe blood-related toxicity, may only require one set of follow-up laboratory tests. In cases of late hematotoxicity, retreatment with antivenom, such as an initial dose of 2 vials, is recommended. However, late thrombocytopenia may be more resistant to antivenom treatment. Blood product replacement is generally not advisable when active coagulopathy and circulating venom are present, unless there is catastrophic bleeding. Cost is an important factor to consider, as antivenom therapy, especially FAB-AV, can be quite expensive. This has led to ongoing discussions about whether maintenance dosing or treatment for mild envenomations is necessary. Evidence suggests that conservative or as-needed dosing strategies can reduce the use of antivenom and decrease the length of hospital stays without negatively impacting patient outcomes such as bleeding or the likelihood of readmission. While antivenom effectively halts the progression of tissue damage, it generally does not reverse existing tissue injuries or prevent tissue necrosis. Therefore, timely administration is critical for halting further damage, but it cannot undo damage that has already occurred. Maternal envenomation may have adverse effects on the fetus. Antivenom is indicated in pregnant patients under the same criteria as non-pregnant patients. However, pregnant women should be closely monitored for late hemotoxicity, given the risk of spontaneous abortion associated with envenomation. Regarding drug interactions, patients taking beta blockers may show less responsiveness to epinephrine used during allergic reactions. Nonetheless, this issue is not considered significant in the context of antivenom therapy. Healthcare providers should still carefully weigh the benefits and risks when considering antivenom treatment for such patients. North American coral snakes belong to the family Elapidae and include several species that are medically significant. Notable examples are the eastern coral snake, scientifically known as Micrurus fulvius fulvius, and the Texas coral snake, known as Micrurus fulvius tenor. Bites from these snakes are primarily characterized by neurotoxicity, which often occurs without significant local tissue injury or hematologic effects. This feature helps differentiate coral snake bites from those caused by pit vipers. Production and availability of Naxav have a complex history. It was originally manufactured by Wyeth Laboratories and licensed in 1967. Production was temporarily halted in 2003, with existing lots expiring in 2008. In 2009, Pfizer acquired Wyeth and resumed the production of Naxav in late 2019. Currently, Pfizer supplies this antivenom on an as-needed basis. Due to its rarity, hospitals typically do not stock Naxav regularly, but supplies can often be located through the Antivenom Index, a collaborative effort between the Association of Zoos and Aquariums and the American Association of Poison Control Centers. Adverse reactions and safety concerns are significant when using an equine-derived whole immunoglobulin G product such as Naxav. This product carries a considerable risk of immediate and delayed allergic reactions, including anaphylaxis and serum sickness. In the past, another equine-derived antivenom produced by Wyeth Laboratories, which was used for treating crotalids, had an 83% incidence of allergic and serum sickness reactions. Premedication with antihistamines and corticosteroids generally has not been proven effective in preventing adverse reactions. Although epinephrine premedication can be hazardous, some recent studies suggest it may be beneficial in high reaction rate antivenoms, especially in resource-limited settings. Testing patients for allergy to the antivenom before administration is considered both useless and potentially dangerous. Such testing can cause allergic reactions, fail to predict reactions accurately, and may sensitize the patient. Patients with a known allergy to horse serum or previous exposure to equine antivenoms should only receive Naxav if the potential benefits outweigh the risks of adverse reactions, and immediate management of anaphylaxis should be available. When treating pregnant patients who meet the criteria for antivenom therapy, it is generally recommended to proceed, as the health of the mother is typically a greater concern than potential unknown risks to the fetus. Continuous monitoring of both fetal and maternal health is essential during treatment. The safety of NAC-SAV during breastfeeding remains unknown. In cases where NAC-SAV is unavailable, supportive care becomes the primary treatment approach. This includes measures such as mechanical ventilation in cases of respiratory failure. While paralysis caused by envenomation is reversible, the recovery process can extend over many weeks. The use of acetylcholinesterase inhibitors like neostigmine has shown inconsistent success in treating neurotoxicity caused by coral snake venom. However, administering neostigmine can be considered if there is a delay in obtaining antivenom. There are antivenoms available in Central and South America, such as the polyvalent anticoral antivenom from the Clodomiro Picotto Institute and F-2-coralmin from the Instituto Bioclon. Nevertheless, their effectiveness against North American coral snakebites is not fully established, and these products are not commercially available in North America. Some antivenoms from other regions have shown experimental evidence of cross-neutralization. Envenomation from a snake or marine creature can lead to several serious complications, each requiring specific management strategies. One of the primary concerns is paralysis, which can affect the patient's ability to breathe. Neurotoxins present in the venom may cause paralysis, posing significant challenges for medical management. Early detection of neurotoxic effects and administration of appropriate antivenom are crucial steps to prevent severe paralysis. If paralysis becomes severe, especially due to neurotoxins that are irreversible and act on presynaptic nerve endings, the focus shifts towards maintaining adequate respiration. This is typically achieved through intubation and mechanical ventilation to assist breathing. When coagulopathy, a disorder affecting blood clotting, is present, it is preferable to perform endotracheal intubation rather than tracheostomy, as the latter carries a higher risk of complications under these conditions. Patients may remain fully conscious despite being paralyzed, which requires healthcare providers to pay close attention to their psychological needs and provide appropriate support. In cases of coral snake envenomation, aggressive airway management and ventilatory support are essential due to the increased risk of aspiration pneumonia, a lung infection caused by inhaling food, stomach acid, or saliva into the lungs. Management of coagulopathy and hemorrhage primarily involves neutralizing circulating procoagulant or anticoagulant venom components with adequate antivenom. It is generally not advisable to routinely replace depleted coagulation factors and fibrinogen with products like fresh frozen plasma while active venom is circulating, as this can worsen fibrinolysis. Such replacement therapy should only be considered after procoagulants are neutralized, indicated by improving coagulation parameters, or in cases of catastrophic bleeding. The return to safe coagulation function is typically rapid, often within a few hours. Local tissue injury and compartment syndrome often involve necrosis, which typically requires conservative care. Administering antivenom is crucial to minimize or eliminate tissue damage. Surgical procedures such as fasciotomy, which is used to relieve pressure, are often overused in the management of snakebites and can lead to long-term functional deficits. This procedure should only be performed when there is clear evidence of significant compartment syndrome, such as confirmation by intracompartmental pressure measurements. Additionally, any coagulopathy should be controlled or reversed before considering surgery. In cases where pressure within the tissue is elevated but blood flow to the affected area is still maintained, administering additional antivenom can be a reasonable initial step. This approach may help lower the pressure and potentially avoid the need for surgical intervention. Infection secondary to snakebite is not a common complication. Antibiotics should only be administered when there is clear indication, ideally after conducting culture and sensitivity tests. It is also important to assess the tetanus immunization status of the patient and provide a booster shot as soon as it is safe, taking care to avoid intramuscular injections if there is coagulopathy due to the risk of hematoma. Late hematologic effects, such as recurrent or late-onset thrombocytopenia and coagulopathy, can occur and may lead to life-threatening bleeding. Patients treated with polyvalent immune Fab antivenom derived from crotality snakes are at risk for these complications. Close outpatient follow-up is essential, including measuring platelet counts and coagulation studies 2 to 3 days and 5 to 7 days after the last dose of antivenom in cases of rattlesnake bites. For copperhead envenomation, only one set of tests may be sufficient. Patients should be advised to avoid surgical or dental procedures and activities with high risk until their coagulation parameters have normalized and remain stable. Serum sickness is a delayed hypersensitivity reaction that can occur after the administration of antivenom. Symptoms of serum sickness can generally be managed with oral prednisone, which should be tapered over a period of 2 to 3 weeks, and with oral H1 receptor antagonists. These treatments are usually administered on an outpatient basis. Special populations and follow-up care are important considerations following snake envenomation. Patients with pre-existing illnesses, particularly those on anticoagulant or antiplatelet medications, face a higher risk of bleeding if bitten by a snake with venom that affects blood clotting. Additionally, patients taking beta blockers may have a reduced response to epinephrine, which is used to treat anaphylaxis. Cases involving exotic or non-native snakes require consultation with experts such as poison control centers, zoos, or herpetologists. These specialists can help identify the snake and provide guidance on specific treatments, as the effects of exotic snake venom can vary widely. Hospitals generally cannot stock antivenoms that are not approved by the Food and Drug Administration, as these are typically held by zoos or require emergency investigational new drug applications to the Food and Drug Administration for human use. Pharmacists play a crucial role in sourcing, preparing, and administering these specialized antivenoms, often navigating language barriers with non-English package inserts. Patients receiving antivenom should be closely monitored in an intensive care unit for at least 24 hours. Patients who have received antivenom should not be discharged until their envenomation and any related complications have resolved. It is also important to ensure that a follow-up plan is in place and that patients have been educated about the symptoms of serum sickness, which can occur several days after envenomation. Patients should be advised to seek immediate medical review if symptoms develop. Follow-up appointments are typically scheduled approximately 1 and 2 weeks after discharge, allowing healthcare providers to monitor for any late hematologic effects or other complications. Careful outpatient follow-up is essential for managing potential late effects and ensuring full recovery. Snake envenomation presents a major public health challenge worldwide, leading to significant illness and death, especially in rural tropical areas. This overview explores various aspects of snakebite, starting with the classification of venomous snakes and the epidemiology of bites, moving on to the complex nature of snake venoms and their diverse clinical effects. The discussion concludes with management strategies, including the use of antivenom. Approximately 600 out of 3,000 snake species are venomous and are classified into several families, such as Colubridae, Natricidae, Elapidae, Lamprophidae, and Viperidae. Morphologically, snakes can be distinguished as front-fanged venomous snakes like cobras and vipers, which have high-pressure venom glands that allow for precise venom injection, or as non-front-fanged colobroids, which may have back-fanged or no clear fangs and possess low-pressure venom glands. Elapidae includes a variety of exclusively venomous snakes, such as cobras, krites, mambas, taipans, and sea snakes, which are found globally. These snakes often cause neurotoxic paralysis, but can also result in local tissue injury, blood clotting problems, and muscle damage. In the United States, coral snakes, which belong to this family, are primarily known for their neurotoxic effects without significant local injury. Viperidae, which includes vipers and pit vipers such as rattlesnakes, cottonmouths, and copperheads, are also venomous. They are found on most continents and possess highly evolved, foldable fangs. In the United States, pit viper bites are the most common cause of venomous snake bites, accounting for over 98% of cases. These bites typically cause local inflammation, swelling, and blood-related effects such as coagulopathy and bleeding. Rattlesnakes, in particular, are associated with the most severe clinical presentations and are responsible for nearly all snakebite-related deaths in the country. The family Lamprophidae, specifically the subfamily Atractaspinae, includes African and Middle Eastern snakes with side-striking fangs that can cause local effects, as well as heart toxicity. The epidemiology of snake bites shows that they are the leading cause of death from venomous animals worldwide. It is estimated that there are over 2.5 million venomous bites each year, resulting in at least 100,000 deaths. These accidents disproportionately affect rural tropical regions with limited access to medical care. In the United States, around 5,000 to 9,000 pit viper bites occur annually, with copperheads being the most frequently reported species. Fortunately, death from such bites is rare, with fewer than 10 fatalities per year. The majority of victims are men, and bites often result from intentional interaction with snakes. Snake venoms are complex mixtures composed of proteins, peptides, lipids, carbohydrates, and metal ions. They contain various enzymes, including phospholipases, metalloproteinases, and serine proteases, along with non-enzymatic proteins. The primary roles of these venoms are to capture prey and defend against predators. The composition, strength, and amount of venom can vary significantly based on the snake species, age, diet, geographic location, and even season, which influences the clinical presentation and effectiveness of antivenom treatments. The toxic actions of snake venoms are highly diverse, leading to a range of clinical effects. Neurotoxins, commonly found in coral snakes, mambas, and krites, cause flaccid paralysis at the neuromuscular junction, potentially resulting in respiratory failure. Myotoxins induce muscle damage both locally and systemically, leading to pain, weakness, and the presence of muscle breakdown products in the urine. Blood coagulation disturbances are caused by hemotoxins, which contain procoagulant and anticoagulant factors that disrupt normal blood clotting, often resulting in bleeding problems. Hemorrhagens, a type of metalloproteinase, can damage blood vessel linings directly, promoting bleeding, while necrotoxins cause local tissue destruction and necrosis. The severity and type of clinical effects depend on the species involved, the amount and potency of venom injected, the bite site, and individual patient factors such as age, health, and previous exposure. Locally, envenomation typically causes immediate symptoms such as swelling, redness, bruising, bleeding, blistering, and tissue death. The extent of swelling and tissue damage often reflects the severity of the bite. Fang marks are usually visible but can be small or absent. In coral snake bites, local signs are often minimal, sometimes limited to mild swelling and tingling sensations. The enzymes and proteins in venom, including metalloproteinases, hyaluronidase, and phospholipases, play significant roles in causing local tissue damage. Diagnosis and monitoring involves determining if the patient has been bitten by a snake, assessing the extent of envenomation, and identifying the snake species. Laboratory investigations are essential in this process. Basic tests include urinalysis and a 20-minute whole blood clotting test to detect coagulopathy. More advanced studies encompass extended coagulation panels such as prothrombin time, international normalized ratio, activated partial thromboplastin time, fibrinogen levels, and D-dimer. Complete blood count, particularly platelet count, as well as electrolyte, urea, creatinine, and creatine phosphokinase measurements are also important. Since envenomation can evolve over time, serial testing is crucial. Initial findings often do not reflect the peak severity of symptoms. Patients should undergo repeat tests over several days to identify delayed or recurrent coagulopathy. An observation period of 8 to 12 hours is recommended to monitor for delayed symptom onset or to exclude a dry bite where no venom injection occurs. The general management and first aid for snakebite involve immobilizing the bitten limb and keeping the victim as still as possible. For non-necrotic snake species, such as coral snakes and many Australian elapids, pressure immobilization techniques are considered effective in slowing lymphatic venom spread. However, this method should not be used for bites from North American pit vipers as it can increase compartment pressures and cause tissue necrosis. Pre-hospital care in such cases should focus on immobilization, establishing intravenous access, and rapid transportation to medical facilities. Unrecommended first aid measures include the application of tourniquets, which risk ischemia, attempting to suck out venom, which is ineffective and can cause infection, making incisions or excisions around the bite site, which can worsen injury and enhance venom absorption, as well as using electrical or cold therapies. Hospital treatment centers around the administration of antivenom, which is the definitive specific therapy that binds to and neutralizes venom components. Initial priorities include assessing and stabilizing airway, breathing, and circulation, providing intravenous fluids, and managing pain with opioids. The bitten limb should be immobilized and elevated. Continuous monitoring is essential to detect any progression of envenomation, such as worsening local effects, paralysis, or coagulopathy. The principle of antivenom dosing states that children should receive the same amount as adults because dosing depends on the amount of venom, not the patient's body weight. Antivenoms are always administered intravenously. In North America, specific antivenoms are available for pit viper species. One such product is a polyclonal fab fragment derived from sheep, approved for all North American pit vipers. Usually, an initial dose involves 4 to 6 vials, or up to 12 for severe cases. Maintenance doses often consist of 2 vials administered every 6 hours for 3 doses to prevent recurrent blood clotting issues. Another option is an equine-derived fragment that has a longer half-life, reducing the risk of late coagulopathy and low platelet counts. This antivenom is typically given as 10 vials initially, with additional doses based on the patient's condition. While modern antivenoms are safer, complications can still occur. Immediate hypersensitivity reactions such as rash, itching, swelling, bronchospasm, hypotension, or even anaphylaxis may happen during or shortly after infusion. Individuals who have been bitten by ticks and developed alpha-gal syndrome may be more prone to these reactions, especially when using equine-derived products. Management involves stopping the infusion and administering epinephrine, oxygen, intravenous fluids, antihistamines, and corticosteroids. Testing for allergies before treatment is unreliable and not generally recommended. Delayed adverse effects, including serum sickness, characterized by rash, joint pain, fever, and malaise, can develop 4 to 14 days after antivenom administration. The risk correlates with the total amount of foreign protein introduced into the body. These reactions are treated with corticosteroids and antihistamines. Late or recurrent blood clotting problems are also possible, particularly after rattlesnake bites treated with certain antivenoms. Such issues require careful outpatient follow-up and possible retreatment. It is crucial not to withhold antivenom when indicated because the dangers of untreated envenomation significantly outweigh the risks associated with adverse reactions. Specific antivenom for coral snake bites is used only in symptomatic patients showing neurological signs. This antivenom is derived from horses and is a whole immunoglobulin G product. It is not indicated solely for local swelling or pain. Availability is limited, and it is usually accessed through poison control centers. Due to its nature, it carries a substantial risk of allergic reactions, both immediate and delayed. If the antivenom is unavailable, supportive treatments such as mechanical ventilation are employed. Managing specific complications is an essential part of care. Early administration of antivenom is critical for paralysis, which may necessitate intubation and mechanical ventilation in severe cases. Coagulopathy is primarily managed through antivenom administration, with routine replacement of blood factors generally avoided while venom is circulating unless life-threatening bleeding occurs. Local tissue injury is generally treated conservatively. Fasciotomy is rarely indicated and should only be performed when compartment syndrome is confirmed objectively and blood clotting issues are under control. Infection is not a typical complication and should be managed with antibiotics only if culture indicates infection, with tetanus prophylaxis kept current, avoiding injections into the affected area if coagulation problems exist. Close outpatient follow-up is vital, especially to monitor for late blood clotting disorders and serum sickness. Pharmacists play an important role in sourcing and managing antivenoms, particularly for envenomations from exotic snake species.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.